Now doctor, that's the reason have a good computer and have a good 1 Mbps line. These are the two things which you need to look for. Now biceps reflex, it is very important for what reason? Have you any time examined a patient of cervical spondylosis? Very common. Rajaya, Pullaya, Veeraya, everybody in our villages, what do? They carry heavy loads. Since they work in the agricultural fields, we get the rice to eat, right? So carrying all that heavy load, ultimately there is a compressive myelopathy which will be developing in them. Most common location is C5, C6. They come with neck pain, etc., and they will be developing muscle fasciculations. Whenever you elicit the biceps jerk, typically there is an areflexia. Below the level of the biceps jerk, triceps, everything are hyperreflexia. Because C5, C6 is the commonest location for the compressive myelopathy to develop in the agricultural laborers, railway coolies, etc. So it's a very common location. Now doctor, weakened plantar flexion and that's right, as rightly said by our Guntur student, it is also a common location for spondylolisthesis also, including lumbar vertebrae. Now weakened plantar flexion and inversion of the foot. It is the tibial nerve which supplies the muscles of the posterior compartment of the leg. It doesn't supply the it is the one which supplies the posterior compartment of the leg, hence any involvement of it leads to weakened plantar flexion and the inversion of the foot which get typically affected. If you can't flex the thigh at the hip joint, who is responsible? It is the femoral nerve which innervates iliacus, which is the main flexor in the hip, and the sartorius, which is the main extensor of the leg, is the one which is typically involved. Now doctor, internal capsule, it has a genu, anterior limb, posterior limb, right? Now hemianesthesia, dysarthria, hemiparesis, they are all the problems which can occur when the internal capsule get affected. But the fibers of the smell doesn't pass through the internal capsule. So that is the reason anosmia is not a feature if the internal capsule get affected, is what I want to underscore to all of you. Now with regard to the taste sensation, what is the main pathway? It is the lingual nerve to chordae tympani, to facial nerve, to nucleus solitarius, to VPM in the thalamus, to postcentral gyrus, which is the sensory cortex, is a typical pathway of the taste sensation carriage, is what need to be remembered. So neuroanatomy, out of 20, at least you can expect 6 to 7 very good questions, and neuroanatomy is very easy to master. You hardly need to give your 10 to 12 hours of time to me. I'll make you the best neuroanatomy students, no big deal at all. So you can go to the neurology file, in that we have a neuroanatomy discussion already pre-recorded. So you can review that in the video library. Now doctor, okay, now you must give me one confident answer. Which drug I am talking when I say that drug decreases the frequency of ventricular premature beat and the risk of the VFib, but the it has got a risk of causing asystole, and it is being generally used in myocardial infarction, and it has a very wide therapeutic to toxic ratio. Which drug? Antiarrhythmic I am talking about. Very common antiarrhythmic, which has a risk of asystole, but it is used to decrease the ventricular premature beats at the time of MI, whenever the myocardium is suffering ischemia. Very common question. Question is complex, answer is simple. Yes, you all have injected it when you are a house surgeon, if you at all have managed a patient of MI. Emidaron is one shooter that comes from Dr. Sunain, Kirti and Varangal. Any other answer? Asystole risk will be there. That's right. Dr. Varun rightly answered it as lidocaine, which is the class 1B antiarrhythmic drug, is what need to be remembered. Why normally the parietal cells don't secrete H plus ions and acid? Because they have a H plus K plus ATPase pump, but it is sequestered in a tubulovesicle unless there is histamine, unless there is the acid provoking stimuli. These enzymes won't be released. Unless they are released by exocytosis, then only H plus production occur. That's the reason they are being sequestered in the tubulovesicles is the underlying cause that parietal cells do not normally secrete acid unless they are being stimulated either by vagus or by the histamine, whatever. Now doctor, posterior interosseous nerve, it is at a great risk of being clamped inside the supinator muscle, is one of the important risks where entrapment of the posterior interosseous nerve can occur. If the surgical neck of humerus get injured, not the surgical neck of humerus is injured, what is the important nerve injured, doctor? Axillary. So that is the reason there is a deltoid paralysis is what has to be remembered. The lesser sac, greater sac, how are they both connected with each other? Epiploic foramen. Then the lesser sac in turn is connected with the hepatorenal recess, which is the subhepatic recess of the greater sac, and the hepatorenal recess will then communicate with the right subphrenic recess. You need to review these recesses, but I will give you one quick high yield question which is frequently asked by the examiner. What is the most frequently infected intra-abdominal space whenever there is appendicitis or liver abscess or perforated duodenal ulcer? Is an important question. It is the subhepatic recess is going to be your answer, like a parrot in the tomorrow's exam. Rectum, blood supply. You have to be 100% sure on this important topic, doctor. Rectum receives the blood from the superior rectal artery and a paired middle and inferior rectal arteries. Superior rectal artery is a direct continuation of the inferior mesenteric artery, but the middle and inferior rectal arteries are the branches of the internal iliac artery, is what you have to be 100% sure, which is frequently asked question, doctor. Now let me shoot you a strong early morning coffee decoction kind of a question. What is the first step you want to do? You have a right ventricular MI patient before you. Do you want to ask, sister, get the nitrates, let us infuse? Or do you want to say, sister, get the dobutamine drip, let us infuse? Or do you want to say, sister, get IV fluids, let us infuse? What is going to be your cry when a right wall MI, 2-3 AVF leads me if there is a IV fluids? That's good. Our Vijayawada student shot it as nitrates, and everybody else said IV fluids. So at least let us tell our Vijayawada students very clearly that nitrates will lead to dilatation of the vessels. They are not the preferred one. In fact, the right ventricular MI is one of the important contraindication for giving the nitrates, just like left ventricular MI is important contraindication for giving IV fluids and fluid overloading, because pulmonary edema will worsen. That is what you have to remember. Okay, doc. Insulin, very good. Our all other students online have shot it correctly. Insulin inhibits the hormone sensitive lipase and decreases the lipolysis and the release of the free fatty acids into the plasma. So if there is no insulin, there is no lipolysis, so there is only lipogenesis, hence If there is no insulin, what will happen? Huh? There is lipolysis, that's what I am saying. Insulin inhibits and decreases lipolysis. So if there is no insulin, there is no decrease of lipolysis, hence there is more lipolysis. More release of, every time lipolysis is there, what is formed? From palmitoyl CoA you get acetyl CoA. All that acetyl CoA combined with another acetyl CoA to form acetyl CoA, which is the ketone body. So that is the reason ketone body production typically increases whenever your insulin is typically acutely deficient, is what need to be remembered. What stimulates insulin? Once more, gastric inhibitory peptide may sound inhibitory, not for insulin. Gastric inhibitory peptide and glucagon like peptide, they both are known to stimulate the secretion of the insulin, is what need to be fundamentally remembered. So in the past 13 years, never during this part of the year people study NAD, physio, biochem, micropharma. They are thought to be the dustbin crap where everybody used to read medicine, surgery, gynops. How many times you finished Harrison used to be a frequently question to the classmates. 2 बार हो गया, मैं 3 बार नया पेन खरीद के अंडरलाइनिंग शुरू कर रहा हूं. तो but now you should say 20 questions physiology, every angle turn curve of the Ganong or Vasudevan or any book which is a good book which can give you common issues with clarity, you must be able to review. Okay, doc. What is the difference between alkalosis and acidosis? Have you seen any time a hysterical patient coming to you with increased respiratory rate? Increased respiration leads to CO2 washout. That lead to respiratory alkalosis. Why do they suddenly go into carpopedal spasm? Because increased alkaline pH of the blood will increase the positive charges, negative charges on the albumin. And calcium is a positive ion. So more calcium will go and bind with that more negatively charged albumin, and ionic calcium levels decrease, and that will induce the tetany. So summarize, tachypnea leads to CO2 washout, leads to metabolic alkalosis, increases positive charge, negative charges on the albumin, which will sequester the ionic calcium, leading to fall of the ionic calcium, leading to carpopedal spasm, is what you have to ultimately remember. It's not acidosis, it is the alkalosis which will increase the albumin binding and decreases the ionized calcium, is what you have to remember. Now coming to the thyroid transport, if you look at androgens, what is their effect on thyroxine binding globulin? Androgens decrease the thyroxine binding globulin. How will you remember? Pregnancy may TBG levels will increase. Pregnancy is a state of hyperestrogenism. Opposite you think, androgen decreases the TBG, not increase the TBG, is what you have to ultimately remember.